Hi everyone, I hope you're all doing well. Today we will be discussing Chapter 14. In this chapter, it's going to provide an overview of the intervention process, which includes planning, clinical reasoning, implementation, and review. Please make sure that you read and then go over the chapter objectives before you continue to watch. This chapter has very important information that we're going to need to become those competent practitioners when we work with clients who have mental disorders. We will be discussing problems that we encounter with planning interventions for clients who have those mental disorders that are not usually an issue for interventions with other diagnoses. The roles of the occupational therapist are being responsible for that intervention plan. The OTA has an important role in the assisting of the OT by carrying out the plan, making suggestions based on the needs of the client, and then also sharing ideas with the therapist. The intervention planning in psychiatry is often difficult because, unlike physical disabilities, the cause is more difficult to determine for those that have those mental disorders. There are many unknowns relating to these disorders, like schizophrenia, and how they challenge the person's ability when functioning in their lives. We might see where they need help with like their ADLs, but then we may not also know like what they're thinking or what's going on. So determining the client goals and deciding which goals to work on first can be difficult when trying to restore function in their lives. So new therapists don't have experience with these clients and they haven't really worked with them except maybe in their field work. So during intervention, it's important to make sure you're picking the right path to help them. Occupational therapy practitioners use the theories to view the why the client is having difficulties. So the reason could be from a lifelong illness, or it could be done unconsciously by the patient or client, practicing in that behavior to avoid situations that might be overwhelming, to just avoid them in general. Demonstrating proficiency with several theories is needed to have that ability to treat the right wide range of clients. So we have to remember that each client is different and may require multiple models to find the best course of action, to better understand the client and to meet their needs. So involving the practice model to use, evaluations to administer, and problems to target and which approaches to use are what you would start with. Asking the right questions. Clinical reasoning is a process of analysis, use thinking and feeling. So the questions that you would ask from the core concerns of the clinical reasoning. So we would ask, what is the person's status? What options are available? And what should we do? On page 447 in your book, it has a box and it has more information of other questions that you would ask to go along with these main questions. So if you refer to that to get a little bit more information, or if you have already read, you will have a better understanding of what to do. Using multiple reasoning tracks, including procedural reasoning, so that concerns the disability and the options that you're going to have for the intervention. Interactive reasoning applies to understanding and then also relating to that patient as an individual and their own unique needs. Conditional reasoning includes that what if, so brainstorming events that might change the current condition and what it's going to take to get that client participation that we need in order to have successful treatment. Narrative reasoning is telling a story that will capture the interest and spark confidence in the patient. And then pragmatic reasoning involves getting things done, thinking through problems that might arise, and finding efficient strategies to take care of the details. The OTA is going to collaborate with the OT in this process. And remember, we are some of the biggest advocates for our patients. As OTAs, we have more interactions with our clients. So we're going to have different perspectives than the OT. So this means our practitioner-client relationship might be developed more, and using our therapeutic use of self, which we've talked about, can help us really open up that client and to build that relationship and have them tell us things that they might not tell the OT because they haven't really developed that more developed client relationship. So as we make suggestions to our client, they might be more willing to accept those because they have that better relationship with us. And so that gives us that ability to contribute to the clinical reasoning and ultimately could result in better outcome in client treatment because they're going to initiate more involvement in their care if they feel that we're really talking with them and that we really do care. So just remember to use your therapeutic use of self and ask the right questions, and that will get a better outcome in the end.
Hi guys, so I'm going to start by talking about using practice models to apply clinical reasoning in planning. So in planning interventions, a practice model organizes our thinking. Using a specific practice model or frame of reference is helpful in generating assessment questions on which to base the treatment plan. For example, in OT and OTA, using the cognitive disabilities model could ask questions like, which sensory cues are disregarded by the person? Which sensory cues does he or she attend to? Is the client able to follow a two-step direction? These questions are on page 449 if you're wanting to look at them. The answers to these questions guide the construction of an intervention plan to adapt the client's life situation and to bring the task demands within the person's range of ability. Another model practitioners often use is the model of human occupation. So this is figure 14.1 on page 450. Using this diagram, we can acknowledge the multiple perspectives considered in an overall plan designed by the OT under the model of human occupation. It provides multiple assessment questions to consider, like, does the client have valued goals, and does the client have organized habit patterns? It's pretty self-explanatory and really helpful in guiding the creation of an intervention plan. And then next, we have the steps in intervention planning. The first step is review the results of the evaluation. This should be executed with an open mind, but with a clear idea of what kind of information we are seeking as therapists. The purpose of this step is to obtain the answers to the second and third steps and to learn as much as we can about the client's problems. Intervention planning also entails identifying the client's strengths, including their supports and their resources, their barriers and personal goals, choosing outcomes, and selecting reasonable goals and methods to achieve them. These steps require combining information from many sources in order to learn the causes of the client's problems, because understanding the causes is often the key to the most effective approach to intervention. The book gives a really good example on page 451 of a patient who has poor hygiene evidenced by greasy hair, stained teeth, and body odor. The problem could be rooted from various causes. It discusses how he or she may have never developed good hygiene skills in the first place. He or she may have gotten out of the habit of using hygiene skills, or his or her usual environment may make it difficult to perform hygiene and grooming tasks. These reasons for a client's problem may also derive from their culture, the disease process itself, or even sensory processing issues. These various causes for the client's problem will lead to different ideas about what kind of intervention is needed and where it should begin. And then next, we have the partnership with the client or the consumer. A relationship with the consumer or client should be established before the therapist begins to plan the intervention. This is really important because the client can often tell you what is wrong and help define the problem. Involving the client in planning intervention to the extent the person is capable ensures that the client understands and agrees with the plan as well. This is a huge step in securing motivation towards their goals. The therapist should continue to adjust the plan as the relationships of the OTA and the OT develop and the client's goals become better known or more clear, like it says here on number 2. The next step is develop intervention plan on behalf of an acutely mentally ill person. So engaging the attention of someone who is psychotic and out of touch with reality can often be difficult. Therefore, in an acute care setting, the staff may develop an intervention plan on behalf of the patient, sometimes in consultation with their family members. And then the last step, set specific long-term and short-term goals and organize in order of priority. So in many cases, especially with people who have severe and persistent mental illness, it's possible to come up with a list of 5 or 6 long-term goals and 20 or more short-term goals. All of them won't be equally as important, so the client and the therapist together must decide which ones they want to tackle first. And according to the book, usually only 3 or 4 goals are attempted at one time, but it does depend on the client. And then next, we just have the general goals of psychiatric OT. We should all know by now that all goals should address functional occupation-centered outcomes. The overall aim of occupational therapy, regardless of area of specialization, is to help individuals engage in occupation, to function as independently as possible within the limits of their disabilities and in the context of their choice. All right. And then there are 4 main categories of intervention: health promotion, remediation or restoration, maintenance of function, and prevention. So health promotion applies to all populations, including those with no present disability. Its aim is to enhance occupational engagement for all people. Examples of this would be fall prevention education for the well elderly or homework management for high school students. And then remediation or restoration, this aims to restore or establish a skill or ability, such as upper extremity mobility or the ability to cope with stress at work. Within this category are the special areas of rehabilitation and habilitation. So rehabilitation focuses on restoring the person's ability to function after the disease process has been medically treated. And then habilitation, it's used to distinguish intervention for clients who never developed the functional abilities because they became ill at a young age. And then we have maintenance of function. This is aimed at assisting the person to use his or her remaining capabilities by providing supports. So the long-term outlook for some conditions is that the person will function less and less well as time goes by. It's really important that the therapists work at creating an environment that supports and encourages individuals to care for their own needs and to take charge of their own lives in whatever way they can for as long as possible because of this. And then lastly, we have prevention. Prevention aims to intervene before dysfunction ever even occurs. So prevention is usually applied with populations at risk for which a future problem is predicted. An example of this from the book would be a supportive group activity for children of alcoholic parents. And then lastly, with the 4 categories of health promotion, remediation or restoration, maintenance of function, and prevention in mind, look at table 14.1 on page 456. There are several goals listed on this table, and each goal may be phrased in such a way to focus on one of these 4 categories mentioned on the slide above. With restoration, remediation, rehabilitation, or habilitation in mind, you would begin the goal statement with the verbs such as to develop, to restore, and to improve. Whereas maintenance of function is the focus of goals that begin with to maintain ability to. And then when the focus of the goal is prevention, you would begin the goal statement with something like to prevent deterioration of the ability to. The goals listed in table 14.1 are only a reference point though, and they're not meant to substitute for the highly specific goals that are typically developed for each client.
Okay, so I'm going to be lecturing about how to write an intervention goal first. So when a client comes in has a problem, it's really important to be able to describe this problem as specific as possible, because the more specific the description of the problem, the easier it's going to be to write the actual goal for the intervention plan. So the goal in the intervention plan should be written clearly, and it needs to describe what the person's going to be doing and then the actions that the person's going to perform. On page 456, there is table 14.1, and that just gives a lot of really good examples of mental health goals. So definitely check that out. Another detail about goals is that they must be measurable. And the reason that this is so important is because if the goal isn't measurable, then you won't be able to determine when the goal is actually reached or met. So some details about how to make a goal measurable is including things. You could include like dates or phrases like with 50% accuracy, or like for 30 minutes or something like that. On page 460, it's table 14.3. It's at the top of page 460. Yeah. There are more examples of phrases that you could use to make the goal measurable. The next thing I want to talk about is Roomba Rumba. I'm not totally sure how to say it, but it's a really good tool for determining if the goal is meeting the criteria that it needs to be as effective as it can be. So this stands for relevant, understandable, measurable, behavioral, and achievable. We'll just start at the top with relevant. If the goal is relevant, it's going to be reflecting the client's current life situation and current life goals. This is also going to need to be supported by all members of the healthcare team as well as the client's family. For understandable, the goal needs to be written in plain language, and the reason for this is because if the client or the client's family looks at the goal and is reading it, they need to be able to read it and understand what they're reading as well. For measurable, we already kind of talked about measurable, but some more details of that is it needs to contain one or more criteria for success. So an example of that would be bathing once a day, rather than saying like have good hygiene, because by saying bathing once a day is telling you what you need to do. You need to bathe and how often, once a day, and that's how you be successful to complete that goal. So some other things to include for the measurable part, you could include quantifiable terms, so things like numbers, and then also it's important to include the date that the goal needs to or should be completed by. For behavioral, this is going to focus on what the client must do to complete the goal. So an example of something that the client has to do would be something like perform like a gait activity or something like that. For achievable, this is going to be decided by the client and the therapist working together, and then the goal that the client and the therapist both decide on, it needs to be able to be met in a reasonable amount of time. And okay, on page, it starts on 459, but the majority of it is on page 460. There are bullet points that give examples of this Roomba Rumba. Just gives examples of that being used. So definitely check that out too. The next thing, how to write an intervention goal involving the clients with setting their own goals. So the reason that it's important to include the client in this process is because it makes them feel independent and empowered. And so the OT writes the goals, but it's really important that the book was really specific that they must be in collaboration with the family of the client and the client as much as possible for this. Next thing. Okay, so when it comes to selecting the intervention principles, the reason for this is really just to like organize the thoughts of the practitioner. So if a client comes to you and has a problem, there could be so many different reasons for this problem, right? So determining the reason for the problem is going to help you to form your opinion on which principle should be used for this intervention plan. So an example of that would be like if a client has poor hygiene, like they could be having poor hygiene because it could be like a lack of education. So maybe nobody ever taught them how to perform these tasks to have good hygiene. Or it could be a cognitive issue, like maybe they just simply forget to perform these tasks. Or it could be like a sensory issue, like maybe after they wash their face, they think their skin feels weird or something like that. So that's 3 different reasons for one problem. And so by determining which of the reasons is causing the poor hygiene, that's going to help you determine which principle to use for the intervention. And the book did say that like there isn't a perfect principle for each situation, so you just have to choose which one is the best fit for your situation. Okay, so after the principle is chosen and it's going to explain the client's problem, like we just talked about, then you need to choose the method for this. So some examples of the method are like an activity or the environment, or those are the ones that I'm going to be talking about anyway. So as far as the activity, it should be based on the principles that were previously chosen, sorry, and then the activity really should be created to like address the goals and then meet the goals of the client. And in each intervention plan, there needs to be an activity or an occupational engagement in every single intervention plan. Because the reason is through these activities or engagement in occupation, this is how the client is going to like learn what they're capable of. Maybe they thought that they weren't capable of some things, and like through practicing like these activities and these engagements in occupation, they're gonna learn that they are actually capable of more things than maybe they had previously thought. As far as the environment goes, the environment has a huge impact on the way that, oh shoot, I forgot to scroll through these. Okay, environment. The environment has a huge impact on the way that the client's going to respond to the therapist, but as well as how they're going to respond to the activity. And so there's 2 main terms that go with the environment, and that's environmental demand and environmental support. So we'll start with demand. Environmental demand is an expectation for a certain kind of behavior caused by some part of the environment. So an example of this could be a parent requiring their child to get straight A's. So in this case, the student would be the client, and the parent is a part of the student's environment, and they are demanding or requiring that the student gets straight A's. Okay, and then for environmental support, this is part of the environment that encourages and assists the client to perform a specific behavior. So rather than demanding, this is encouraging and assisting the behavior. And so an example of this would be a case manager calling their clients and checking in on them and being sure that they're still like staying up on their medication. So it's not demanding from them, but more like encouraging and like assisting them and things. And the reason that, or like the purpose for changing or manipulating a client's environment is because this is going to encourage the clients to perform the activities and get engaged in the occupations like we talked about a little earlier. And through the engagement in occupations and participation in these activities, it's going to help the client to develop the skills.
Okay, for therapeutic approach, we've talked about this previously, so what's important to know is that we just make sure to consider the client's values, learning style preferences, and motivation for change. And then with intervention implementation, this is the enactment of the methods and activities outlined in the intervention plan. So the OT has the overall responsibility for this, but then the OTA carries out the plan. The OTA is responsible for asking for supervision and following directions. And then the OTA must be certain that the person is aware of the purpose of the intervention and must help him or her understand why it is important. And this is really important because sometimes people with cognitive impairments or just severe mental disorders forget why therapy is important. And it's our job to make sure that they don't forget that, because that's very important for successful therapy. And then there's 4 suggestions for how to help patient link the activities with their purposes. Number 1 is to explain the purpose of the group or activity. 2 is to encourage the patient to think about the purpose and ask him to share his or her view. 3, discuss the skills used and link them to activities or tasks performed. And 4 is summarize what has transpired. Okay, so for monitoring and modifying the intervention plan, this is done through informal and formal observation and formal reevaluation by the OT. So informal observation, they are made almost automatically. So it's like when you walk in a room and you're watching a patient, and it's just like what you instantly see them doing. Their behavior and their remarks will provide clues on if a task is too easy, too hard for them. Those are those informal observations. And then formal reevaluation is done by the OT. And then intervention review is performed after some of the intervention has occurred. It determines the effectiveness of the plan. It may include reevaluation using standardized tests. So this is where we want the client to be involved in the review process as much as possible, depending on the cognitive level. And then the review done by the OT may lead to modification of the plan or discontinuation of the plan. And that is all overall up to the OT. Information obtained and provided comes from the OTA, and then the OT makes the decision. And then outcome assessment. These are changes that are brought on by the occupational therapy intervention. Outcome measure is chosen at the evaluation phase, and the OT is responsible to perform, and then takes into consideration what the OTA has said about the outcomes. And so with that being said, the OTA must be aware of the client's goals and target outcomes and report all of those to the OT so then they can make their decision. And continuity of care across settings. This is when OT practitioners consider the client's future needs and possible future environments when planning an intervention. And it is in making the transition from one setting to another that consumers are at a risk of falling through the cracks in the mental health systems. And so like when transitioning to a new environment, that's when they fall through and they don't get the help that they're needing, or they just aren't seen anymore. And so it's up to us to make sure that that is not happening. And we can do that through obtaining permission from the client to speak to the OT or the service provider in the next setting, so then we can still be involved. And it is encouraged and allowed and encouraged to call and to make sure the transition has been made, and to ask any questions and to answer any questions that are needed. And quality assurance is a systematic approach to the evaluation of patient care that enables the identification, assessment, and resolution of problems in order to improve healthcare benefits for patients. This is guided by the manager of the entire OT program and carried out by the OT practitioners. And then there are 3 areas where this is assessed. And so it's progress toward goals is the most easily measured when the goals are behaviorally observable and measurable. And then consumer satisfaction with care can be measured through exit interviews, but the most objective and easily assessed is through survey. And then behavior rating can be achieved by using a numerical rating scale such as the Comprehensive Occupational Therapy Evaluation Scale. And these are all done just to ensure that we're having quality care. And then continuous quality improvement is another quality management process. Its monitoring is ongoing rather than retrospective. So it's like the constant care instead of looking back. It is more interdisciplinary than quality assurance, and it looks at outcomes rather than problems. It is also more client-centered than system-centered, and it provides immediate information about the results of the intervention and makes changes as needed. And that is all we have for chapter 14. Thank you.